Today, and very honored to be invited through my colleague Dr. Riyad Abu Sulaiman, and I really feel, although it's the National Guard and it's not Jeddah, I quite feel at home because most people here are either very close friends or even brothers and definitely sisters. So what I will be talking about is coarctation of the aorta, and I'll try not to bother you a lot with clinical issues in coarctation. And thank God the complex issues were given to others, and I was given somewhat a less complex disease, not like Dr. Barim's up, down, and sideways connections. So coarctation of the aorta is a common cause of left ventricular outflow tract obstruction. As you know, when we talk about left ventricular outflow, we mean the subaortic area, the aortic valve, the ascending aorta, and distally the arch. Narrowing usually is located just distal to the left subclavian artery, and this is where really when you do your echocardiography you should concentrate on. This is just a diagram to show you the normal isthmus. This is the area where we call the isthmus. This is your left subclavian, and that's your typical discrete coarctation of the aorta in this cartoon. Coarctation of the aorta is best imaged from the suprasternal notch. Left ventricular outflow, obstructive lesions like significant other signs for it is right or left ventricular hypertrophy without obvious explanation. So if you see this and you cannot be sure that there is a coarctation, there are other indirect signs like right or left ventricular hypertrophy without obvious explanation, or the absence of pulsation in the descending aorta as imaged from the abdominal wall. They all may suggest the possibility of coarctation of the aorta. This is the usual suprasternal view, and I think you went over the normals. This is just to show you an association of a bicuspid aortic valve that you can see. I'm going to show you a lot of images instead of a lot of talk. This is the, see the valve open just as one circle. There's one leaflet here and there's another. 2D echocardiography for coarctation. When imaging a coarctation, one must be certain that the entire aortic arch is imaged, particularly the region of the origin of the left subclavian artery. So you can never say that there is no coarctation unless you have seen the entire arch and you have seen the last branch and a bit distally to it to be sure that you really did not miss a coarctation in your echocardiogram. The coarctation may be either a long segment narrowing, which is the rarer form, but more commonly a short segment obstruction caused by a posterior endothelial shelf is seen projecting into the aorta. In the region of the ductus arteriosus, an anterior shelf, you may see an anterior shelf, may normally exist just proximal to the aortic origin of the ductus, and this should never be confused for a coarctation. Usually it does not indicate any coarctation. This is just an image to show you the normal arch, and you see the last branch here and the distal part. This is your pulmonary artery. You really have to see way beyond the pulmonary artery if you want to exclude coarctation. You cannot just see this part and say it's fine. When you Doppler also, you cannot just Doppler a little bit higher and you're fine. The coarctation sometimes is quite low. So this is the color Doppler, and you see how the color is quite laminar. No turbulence, neither from the ascending or the arch, the transverse, or just below the subclavian. Even distally, you could see that the color are laminar or the same pattern. This is the abdominal aorta, and you see again it's quite nicely pulsatile by color Doppler. This is not enough to see, but it's assuring to see that the color is very easily obtained and it's not different. Another way of looking at an aortic arch in babies is the subcostal view. And occasionally in a baby who's crying and when you are not able to see, some of these kids are emphysematous. You don't see the suprasternal view quite well. You may go subcostal and you'll be lucky to see this cane stick, Kaz sign, as we always say. You see the arch and you may be able to see quite well. Still, there is a difficulty in this view that the distal area to the subclavian is usually not well imaged. Occasionally it's well imaged and you can see it. Here we were lucky to see that. You see the color. When it's coming down towards the probe, it's red, it's not turbulent, and it's ascending also blue and not turbulent. But again, as I said, this area by 2D you can never be sure of, but it gives you an idea when there is the difficult case. This is just a still image to show you the long segment coarctation. See, this is the subclavia, and it's displaced laterally. You see, there's a big distance between it and the second branch. It's way pushed down and lateral. And then you get your long segment coarctation. This is another still image of just a discrete one with the posterior shelf or the endothelial projection into the isthmus of the aorta. The severity of an aortic coarctation can be assessed by Doppler examination. Color flow imaging of the descending aorta is performed looking for a high velocity jet in the region of the suspected position or possessing a coarctation. What's a high velocity jet? It's a turbulent jet. It's either turbulent mosaic or turbulent red or turbulent blue. Usually it's a mosaic color combined of the three. This is what you get in the abdominal aorta in a coarctation by Doppler. See how damp the flow is? It should be nicely pulsatile, more than 0.8. This is hardly a 0.4. And you see the forward flow in diastole, because the pressure in the ascending aorta remains high in diastole. You still get flow throughout diastole, and it's not the usual negative blip that we see in the usual abdominal Doppler because of the cerebral flow. This is somebody with a very tight coarctation. Continuous wave Doppler beam is directed. You see, this is the arch, and this is below the pulmonary artery. This is where your beam is put, and into the area of flow velocity, recording usually a high velocity jet. This guy or this patient has at least 4 meters per second or even more. So this is a gradient of at least 64. You see again the diastolic continuation or forward flow, anterograde flow during diastole. From the peak velocity, as an echocardiographer, whether a cardiologist or a technician, you can calculate the pressure gradient, and it's an important information in the echo, because we can say by 2D it looks tight, by color it looks turbulent. At the end of the day, we want a difference in pressure to tell us the severity. The equation is very simple. It's the simplified Bernoulli equation. You multiply 4 by the velocity you got by the continuous Doppler, which was squared, then you get your result. Left heart obstructive lesions in series, like bicuspid aortic stenosis, subaortic membrane, can lead to an increased flow velocity proximal to coarctation. So in coarctation, another caveat, another problem, if you have obstructions before it, what will it do to your velocity in the obstruction? It will definitely increase it, because it's multiple areas of stenosis. Once you see that, then you have to be careful of what you call coarctation and how to grade it. You have to take in account what we call the V1, or the velocity before the coarctation. So you will take a Doppler before and a Doppler after. Usually this is a pulse Doppler, no more the continuous. And minusing the V1 from V2, you can get your true coarctation gradient. In the presence of significant coarctation, the abdominal descending aorta, as we said, shows a continuous anterograde flow. Postoperative assessment of these patients, the most common problem that can arise in postoperative coarctation repair, especially in infancy, is the presence of residual arch obstruction. It can occur at the surgical site itself. So again, in the post-op, you want to see this patient, and can be due to previously unrecognized segment hyperplasia. See, when the arch is obstructed, the most distal obstruction governs the previous obstructions. So you can correct that, then you can unveil the previous obstruction. A lot of the time, the surgeon goes and does the coarctation and then finds that actually there is a hypoplasia at the isthmus, and then you get a gradient there in you. Patients who have had a coarctation repair can develop aortic aneurysm at the surgical repair, and the aneurysm usually is defined as something 1.5 times the descending aorta below it. That's another thing to look for. After surgical repair, patients with arch obstruction can have progressive increase in the severity of their associated defects. Somebody with a mitral stenosis association, a subaortic stenosis association, may have it worsening after that because it's a continuous evolving process rather than just a fixed lesion. The most frequently associated defects are ventricular septal defects in 44%, bicuspid aortic valve in 42%, not necessarily stenotic or not, valvar aortic stenosis in 8%, subaortic stenosis in 8%, and mitral valve abnormalities in 4%. Of interest, the bicuspid aortic valve was more commonly associated with an isolated juxtaductal coarctation, whereas ventricular defects are associated with isthmus hypoplasia, the more longer type of a coarctation. Abnormalities in the left ventricular function can be detected in the postoperative coarctation patient. So coarctation, you don't just go for the 2D or that segment of the aorta. Coarctation has effects on the function of the left ventricle, and that's important. So we can assess those, especially in the postoperative patient. Not uncommonly, these patients have endocardial fibroelastosis, and if you have seen this, this is a very bright endocardium, fibrous-like, that can prevent a good diastolic function. Abnormal diastolic filling pattern through the mitral valve inflow. When you Doppler your mitral valve inflow, you may find E-wave, A-wave abnormal relations. Interruption of the aorta is the most severe form of coarctation. Usually it's distal to the second branch of the aorta, and this is an example for it. You see, this is your ascending aorta, first, second branch, and suddenly we miss a big piece here. And there is the continuation with the ductus. This is the angiogram of it, the echocardiogram, and you see the interruption. It's important to get this piece because the surgeon may ask you, what's the distance? Is he going to need to put an interposition tube? Usually this is very uncommonly done now. Most surgeons will be still able to pull out that abdominal aorta or that thoracic aorta up to the arch. This is a very rare association, but it is one of the left to right lesions that can lead to arch hypoplasia. This is a patient with AP window. And you see coarctation or left side obstructing lesions, they are commonly seen when the blood is drawn away from the LV, like in total anomalous, like in large VSDs, like in AV canal. And this is one method to take away the blood from the aorta, and you end up with an interruption. Suprasternal views show a relatively small ascending aorta in interruption. The most common situation is for the innominate and left carotid arteries to originate first, and then you get your segment. Caution should be exercised that the ductus arteriosus connecting the main pulmonary artery not to be mistaken for the arch, because usually in these patients it's quite a large ductus. And the differentiating point is that it does not give any branches. And that's how you say this is not an arch. With adequate patency of the ductus arteriosus, the abdominal aorta pulsatility can be normal. So an interruption, don't be deceived by that. Actually, don't be deceived even clinically, because the pulses may be normal if the ductus is open. Color flow mapping can show total absence of high velocity jet in the descending aorta because the ductus is widely patent. So you will not get a gradient. Now we'll go just to the 4 minutes I have, or the 3 minutes? 3 minutes. I'll just show you images of coarctation and just go over them. Here, there's probably a narrowing somewhere there. Let's see, with color Doppler, here we're suspecting it by echo. It's not as clear. We do see some sort of a shelf. And look at this tight coarctation. And it's quite low again, but it's not very low because we still see the PA there. This is the same patient. Just gonna go. So where is this coarctation? Is there a coarctation in this patient? Huh? Any answer? Any taker? Is there? We'll see. Well, this patient does not have because we're way below. You see again, way below, huh? But we'll give you things that can show. This is again the same patient. Okay, this is another sign of detecting coarctation. If you see the subclavian so much pushed down and displaced laterally, even if you don't see a coarctation, you should say, I highly suspect a coarctation. No gradient or a gradient, you saw the shelf or you didn't, this must be something to consider. And look in this patient, how it actually was. Look at the subclavian where it is, and look at what the coarctation is. Very further down. And probably this could be easily missed if somebody did not concentrate on the displacement. This is again showing the displacement with arch hypoplasia. So this is where, if you repair, you may get an obstruction here. The surgeon may want to do it. Usually, if it's more than 3 millimeter by echo, we're okay in a neonate. And you see, this coarctation is very low again, and it is juxtaductal. And the ductus may close and pinch off completely, or may keep open. We don't know, and usually we observe these patients intra-hospital. This is a patient with the retrograde flow in a PDA. You see, in coarctation, we saw the anterograde flow. Again, a very tight coarctation here. You see, it can get as near atresia. It can be long segment and low. Again, the same. And here, what are you seeing? I call it the three-pod sign, the three-finger sign. Very bad when you see it in the short axis view. It is horrible to see. Right pulmonary artery, left pulmonary artery, and another leg here, and this is the ductus. When you see this, highly suspect a tight coarctation or even interruption. And you see the ductus here is wide open, and we see some part of the descending aorta. Occasionally, in coarctations, especially in syndromic children, we get the lungs also involved. So hypoplastic lesions on the left side can have hypoplastic lesions on the right side. This is a patient with coarctation and distal RPH stenosis. What would be a possible diagnosis? The Noonan, Turner, William connection. One of those can give you such a thing. This is a beautiful coarctation, hardly to miss. You just can't miss this one, but they almost always don't come like this. And this is again the same picture. This is again a nice one. They're hard to get, but you see it's a long segment. May not be suitable for ballooning, but the interventionist may say still I'll take a go. Okay. Yeah, I'm coming. Are we done with time? I just want to show one thing more. The LVH is very important to assess, and also if the ventricle function is good in these patients. Tight coarctation. Bicuspid aortic valve, see the fish mouth? How is it opening? It's 2 leaflets again, only. And what is this? Is this coarctation or is it something else? Who's a taker? You think it's coarctation? The flow here is turbulent, isn't it? It's quite turbulent. Is it coarctation? Coarctation, raise up your hand. Not coarctation, don't raise up your hand. So you all say it's not a coarctation, or you don't want an answer actually. Actually, this is not a coarctation. You see, the turbulence starts in ascending aorta. This is somebody who could have a supra-AS or an AS or a sub-AS. And you have to be careful, and that's how we said multiple in-series obstruction can be difficult. This is a huge ductus, and this is most likely an interruption patient. And you see how the ductus can be, and this patient can go into severe heart failure. This is just the same long segment. And I think I can stop here if the time is finished, unless you want to amuse yourself and see some images. Again, a tight coarctation. Okay, thank you very much for your audience.